All right, so take two. Sorry, the good old NVIDIA. Uh, Excellent graphics cards. So where was I? All right, so cephalosporins. So one of the things that's important about cephalosporins is that they are essentially resistant to beta-lactamases. Now that's not going to be true for absolutely every last beta-lactamase because, like we said, unfortunately the gram negatives are pretty good about supercharging their beta-lactamases and overcoming resistance, but at least that's the general idea of cephalosporins is they tend to be resistant to these. So let's just do a little bit of a chart here, a little table. So the way we kind of break up cephalosporins is into generations, and um, we will have a first generation, we will have a second generation, we'll have a third generation, we'll have a fourth generation. Actually, let me give myself a little more room for the. Thank you, Microsoft. All right, we'll have a fourth generation, and we'll have sort of a fifth or advanced generation. Now, probably the way you were initially taught the cephalosporins is first generations are good for gram positives, and as you go down, you get better gram negative coverage. But the reality is, just like we have been talking about, is that that's just unfortunately too facile a way of thinking about these things. So let us move over and give ourselves some room. We'll have, let's do some oral, oh, sorry, let's do IV, and we'll do oral. All right, and let's see. Can I use a line? Let's see. Make my. Oh, look at that. Make a straight line. Okay. We have IV, and we have some oral ones. All right. This probably should have done this a little better, but that's okay. All right. IV. So, IV first generation cephalosporin, easy. Cefazolin or cefazolin, whichever you prefer. Um, my in fellowship, I had a German fellow who was above me, and she would always call it cefazolin. So I think we kind of stuck on cefazolin after that, and once in a while my head still goes cefazolin. But other than that, it's cefazolin or cefazolin, whichever you prefer, and the oral form is cephalexin. There are other both IV first generation and oral, but these are the ones that you pretty much see being used, at least in the US. Um, so we'll just talk about those guys. In terms of second generation cephalosporins, what do we have? We've got cefoxitin and cefotetan. And oral, we have cefuroxime. And we unfortunately don't use probably enough second generation cephalosporins like we should. There is something unique about them, so we'll talk about that eventually, but let's just talk about this for. And then in terms of third generation is where things are going to get even more complicated. We have ceftriaxone, of course, is the ceftriaxone. Why some have PHs and others have Fs. Don't ask me. I don't know the answer. I've never heard the good answer, but if somebody knows, leave a comment or something. I'm more than happy to learn. So we have ceftriaxone, we have cefotaxime, although unfortunately cefotaxime has been harder and harder to find, though certain places still have access to it, and lucky for them. We have ceftaz, ceftazidime. And in terms of oral, we have a whole bunch. We have cefdinir. We have cefixime, also known as Suprax. Cefdinir is also known as Omnicef, is commonly what it's called. And although, again, try not to use brand names. Try to use generic names because that tells you a little bit more about what you're treating. I see a lot of people saying Zosyn, not even realizing that What's important about Zosyn is that it's piperacillin tazobactam, and when you hear piperacillin, it should remind you, oh, penicillin, oh, they're anaphylactic to penicillin. Maybe Zosyn is not the right answer, but anyway, piptazo is a better way of calling it. Anyway, all right, so we have ceftonir, also known as omnicef, cefixime, cefpodoxime. And there's actually another one that's kind of interesting. We'll just mention it briefly. Cefditorin. But it's really, I can't think of anywhere where I've seen it being able to be found or dispensed. So it's sort of not there, even though it has a kind of a curious change. All right. Fourth generation, at least in the US, is pretty much just cefepime. You're probably thinking, oh, it's interesting that some of these are green. And in terms of advanced generation cephalosporins, there's a few new ones, but the big one that we'll talk about is ceftaroline. Ceftaroline. There's a few new ones also, like cefiderocol, which doesn't even work with the classic mechanism. Why is this one so much bigger? Oh, that's why. That's why you're so chunky. All right, sorry about that. Cefiderocol. And I don't believe there's any new oral agents at the moment, but hopefully we'll see some in the future. All right, so let's look at gram positives. So let's just talk about gram positives for a second. So what are the gram positives that we've been mentioning? So again, one of the things that is easy to sort of get caught up in is just say, okay, first generation cephalosporins work on gram positives, and as you go down, it changes. That's not even true. But importantly, we went through this whole business of dealing with these gram positives. Why? Because these are the most clinically relevant, most commonly encountered ones. So let's just write them out. Let's start out with good old MSSA. We have MRSA, we have group A strep. We'll just leave viridins out of this equation for now. We have pneumo, we have fecalis, and we have fecium. All right, now let's get out my ruler here. Let's just extend our lines here. We can make a nice little table. Oh, that was pretty good. All right. So you just go like that. Okay. So let's start. Let's look at something pretty easy. Let's start out with group A strep. All right, do first generation cephalosporins work on group A strep? Yes. Do second generations? Yes. Do third generations? You betcha. Do fourth generations? Yes. Do fifth generations? Yes. All of these guys work on wimpy old group A strep. Group A strep, remember, what's the drug of choice though? It's just regular old simple penicillin. Why use cephalosporins and all this other additional stuff that you don't need when it works just when penicillin, good old penicillin works, or amoxicillin. I'll let you get away with amoxicillin for kids. Only kids. Adults, you stuck using penicillin. But that's the drug of choice. I mean, you don't need something that's resistant to beta-lactamase when something doesn't produce it. Let's pick another easy one. Let's start with MRSA. Do any of these work on MRSA? Well, remember, what's MRSA's mechanism of resistance? Remember, it has two. It has production of beta-lactamase, and it has an altered penicillin binding protein, which means it doesn't matter if the cephalosporin is resistant to the beta-lactamase if it's altered its penicillin binding protein. Unfortunately, it's altered it in such a way that no matter how much you give of these things, you will not overcome that. So none of them are going to work, with one exception. No, First generation, cephalexin, cefazolin, no. Second generation, no. Third generation, dead in the water. Fourth generation, absolutely not. The one exception of a beta-lactam that MRSA is susceptible to is ceftaroline. Ceftaroline is an excellent antibiotic for MRSA, and why is that? Well, first of all, it's a beta-lactam. You don't have to struggle with vancomycin and all its dosing and stuff, or you don't have to struggle with all those issues with linezolid or daptomycin or that. We have an excellent beta-lactam antibiotic that was specifically designed to deal with that PBP2A gene. Ceftaroline is the sort of exception to that rule where we get MRSA coverage. And again, what am I doing here? Why is that making lines? Okay. So this is the one exception to this rule is that ceftaroline works on that. None of the others do. Carbapenems don't work. You can pick all the beta-lactamase inhibitors in the world you want. It won't matter because of that MEK gene or the PBP2A gene. But ceftaroline is the exception. All right. Let's take another couple easy ones. Let's do fecalis and faecium. Well, it turns out that both of these are not very susceptible at all to cephalosporins. So you basically just have to say no. Uh, a little bit of an exception is fecalis, like we talked about, is a little wimpier. So there's certainly been cases where somebody has an E. fecalis UTI and they get a big whopping dose of ceftriaxone just because they're sick and somebody said, let's give them ceftriaxone. And they actually managed to clear, probably because, again, a lot of these beta-lactams are concentrated in the urine. And so if they're concentrated in the urine, you're getting really high levels. And sometimes you're able to overcome the intrinsic resistance. But in general, we would not say please use ceftriaxone for that. Intriguingly, ceftriaxone in combination with ampicillin is sometimes used for E. fecalis endocarditis as an alternative, and so there is some synergy. But in general, you wouldn't just treat E. fecalis with ceftriaxone. So I'm going to give it an X with a little caveat that once in a while, like endocarditis, or once in a while, you'll have some clinical success. But faecium, absolutely not. Cefepime, nope, same deal. Ceftaroline will, I think, work on fecal, but again, it's not. You wouldn't generally be using that when you can use good old ampicillin instead of using a multi-thousand-dollar antibiotic that needs to be saved for drug-resistant infections. So pretty much not a good go for any of these. Which now leaves us with just two bacteria where there's some nuance. And this is where when people sort of say, oh, well, first generations are great for gram-positives, that's what they mean. But really, you've already seen the nuance. MSSA, first generation cephalosporins, tend to be excellent. So the equivalent to oxacillin and the semi-synthetic penicillins in terms of their activity. So really, it gets an A. Just an excellent alternative agent for MSSA infections, but of course not MRSA infections. How about second generations? They actually work pretty well, so we'll give it like an A minus, B plus. Their activity is a little bit lower than first generation cephalosporins in terms of their coverage of MSSA, but not bad. And then third generation cephalosporins do in fact have some activity against pneumococcus, against Staph aureus, but the activity is lower. It's not as active, meaning you would have to use more of it, and it doesn't kill quite as well as it does for MSSA, and so we tend to give it like a C in terms of its activity. Just yes, if you look at the package insert, it'll say you can treat Staph aureus infection with MSSA, but it would not be a first-line go-to if you had somebody septic and dying of a MSSA pneumonia. Ceftriaxone would not be a good choice for them. And this is where things just get flipped on their head. Cefepime, it turns out, actually tends to have excellent activity on MSSA again. So you can't even go down the list and say, okay, well, it's getting worse as you go down for gram positives, when really we're just talking about MSSA, right? MRSA, they were all bad. Fecalis, they were all bad. Faecium, they were all bad. Group A strep, everything works. So it's really MSSA, and fourth generation cephalosporins buck the trend, and they're once again can be quite useful clinically on MSSA, especially if you got like a tracheitis with Staph aureus plus, some gram-negative like Enterobacter that you need to deal with. It's perfectly reasonable to treat them with monotherapy with cefepime. Ceftaroline will also work on MSSA, but I'm just going to put an X there just to remind you not to use ceftaroline for an MSSA infection when you can use good old cefazolin for an MSSA infection. So that's me lying to you to keep antibiotic stewardship in play. Pneumococcus is weirdly a little bit more like a quote gram-negative in that first generation cephalosporins are very bad in terms of their activity for pneumococcus. You do not want to use that. If you think about it, when was the last time you used cefazolin to treat acute otitis media? You don't. Amoxicillin works well, but first generation cephalosporins don't. Why is that? It's just the way it is. Second generations tend to again have some better activity, and this is where things get even more annoying. Is the third generations. So I'm gonna break it up into a box because there's just this annoying amount of nuance for pneumococcus. Ceftriaxone, cefotaxime are both excellent choices for most pneumococcal infections. So we're going to give it an A minus, and I'll tell you why we give it a little A minus, and that's just to remind you. So ceftriaxone, cefotaxime, essentially equivalent in terms of their activity on pneumococcus. The reason it gets a minus is just to remind you in general, the vast majority of pneumococci will be susceptible to ceftriaxone. It's more potent than penicillin. So, in terms of like cases of pneumococcal meningitis, where you have a little bit more trouble getting across the blood-brain barrier, and therefore drug levels are lower because it's more potent, you get that additional activity even when you're dealing with many of the pneumococcal strains that have alterations in their penicillin binding proteins. They still remain susceptible to ceftriaxone because of that improved potency. But guess what doesn't work? Ceftaz. Ceftaz just does not work on pneumococcus. Don't use it. And again, it's just one of those nuances you just have to know. Because you can sit there and go, well, it's a third generation cephalosporin. Ceftriaxone works just fine on pneumococcus. Shouldn't ceftaz? The answer is no, it doesn't. And this is where the oral third generation cephalosporins are also bad. Let's give them a C too. And the reason is none of these, with the exception, interestingly, of the ceftatorin, get very well orally absorbed, which means you're running into the exact same problem of using just good old oral penicillin for a pneumococcal infection. Even though high-dose amoxicillin will treat about 90% of pneumococcal infections, this almost brings you right back down to oral penicillin's level because you just can't get high enough levels to fight those more resistant bugs. So again, you'll treat the exquisitely susceptible strains of pneumococcus just fine, but you will not treat those more drug-resistant ones. So they're really actually pretty awful in terms of their antibiotic profile and why they're so commonly used in pediatrics, especially where you're dealing with children, especially with recurrent acute otitis media. They're not really that great a choice, and unfortunately are massively overused, causing a whole lot of exposure of these gram-negatives to treat something not even that well. And so that's why I really think a lot of ID docs hate on oral third generation cephalosporins. They have their use, but they are not very good, especially for what they're typically used for, which is sinus infections and acute otitis media. All right. So I think that's our little, and this is the extra box for no good reason. All right. So, see, complicated. There's no other way to do it other than just know that. And I don't think there's an easy mnemonic to go through either. Cefepime, once again, introduces excellent pneumococcal coverage. Again, same problem though, is can you have about 5% of pneumococci are so drug resistant. They've altered their proteins so much so that they become resistant to cephalosporins, and you're going to have the same problem with fourth generation as you are third. But they again introduce pretty good. So here's something weird, right? It works on both MSSA and it has good pneumococcal coverage. There's just no rhyme or reason to it other than that's what happens. Ceftaroline also is thought to do pretty well with drug-resistant pneumococcus. It might actually even be better than an A minus. I'm not going to give it a plus, but I am going to just give it. We'll give it an A, maybe minus. Let's do a minus. There's just not enough data to really support its use, especially in pneumococcal meningitis, at least at this point, and maybe that'll change. All right. So you can see the situation with the gram positives is a little bit complex, and you just kind of have to know some of that. So is what it is. All right. So where does that leave us? So let's talk about the gram negatives. I wonder if I can just move this chart over. Let's see. Oh no, that's too much. Oh, no, worked perfectly. Great. Oh no, no. Will undo work? Maybe. Maybe not. All right. Let's move this guy over. And now let's look at our gram negatives. The gram negatives, fortunately, are going to be a little bit more straightforward. Gram negatives. All right, so first generation cephalosporins. Hopefully you recall. Just move my little picture over a little bit. Okay. This is the PEC. And what does that stand for? Proteus, E. coli, Klebsiella. So the first generation cephalosporins tend to work on these and not a whole lot of other gram negatives. And so that's where that mnemonic came from, PEC. You do have to be, of course, cautious in the modern era of drug resistance. There's tons of E. coli, tons of Klebsiellas that are resistant to first generation cephalosporins. So it's sort of PEC with an asterisk, as you probably at this stage need to have a culture and actual susceptibility data before you can declare it susceptible to a first generation cephalosporin, but it doesn't really have activity on all these other guys. So that's sort of its range anyway of possibilities, even though it's not necessarily fine anymore. The second generations introduced this idea of HENPEC. So you keep the PEC, but Proteus, E. coli, Kleb, but you add Haemophilus, um, Enterobacter, and Neisseria. The trouble is, unfortunately, Neisseria is starting. I mean, while it'll be fine for Neisseria meningitidis, these second generations, you have to be careful about getting into the blood-brain barrier. So not a great one for Neisseria meningitidis, and to boot, gonococcus is becoming more and more resistant. So the N is slowly fading out of existence. Uh, the Neisseria, it turns out Enterobacter also has this whole idea, and we'll talk about that when we get to the third generation cephalosporins of the M space organisms and inducible AMP-C containing bugs, but Enterobacter is probably not that great for Enterobacter anymore, leaving kind of back for second generation cephalosporins. So yes, they add a little bit. You'll get some Haemophilus coverage, but pretty much back to PEC. A little bit broader in terms of its resistance to some of the more resistant ones. But this is where third generation sign is they really have broad gram negative activity, improving their E. coli, Klebsiella, Proteus coverage, Citrobacter, certainly Salmonella, as long as it's not multi-drug resistant typhoid. In general, third generation cephalosporins are pretty good. If you have somebody really sick with a non-typhoidal Salmonella, then a third generation would be excellent for. So they work on that. This is one more where there's a little bit of a caveat, where great for Neisseria meningitidis, now the drug of choice for gonococcal infections. Certainly will work on Haemophilus marxella. Not Bordetella is sort of its own beast, so that one we'll just leave out of the discussion. But these will work pretty well for most gram negatives. The one exception is no Pseudomonas for all of them except for, well, we made it in green for a reason, Ceftaz. So Ceftaz has equals Pseudomonas. Um, so Ceftaz does have that. Ceftaz actually did have some activity on steno as well, but unfortunately those days are numbered and most strains tend to be resistant. Cefepime again has broader, and this is where we're going to talk about Enterobacter. So Enterobacter. So here we had to be questionable Enterobacter, and here we have pretty good Enterobacter coverage. And let's talk about Enterobacter. So there's this group of organisms called the M space, or M spice. M space. Some people call them M spice. There's actually a whole lot of acronyms. It stands for Morganella, Morgani, Serratia, Proteus, or indole positive. A is for Acinetobacter. C is for Citrobacter, Citro, and E is for Enterobacter. And of these organisms, they can sometimes have something called the AMP-C cassette. And what AMP-C is just, if we remember going back to clindamycin, right, there was inducible resistance. Well, the AMP-C cassette is just like that. It is an inducible, unfortunately, extended spectrum beta-lactamase. So where you start to see resistance, so E. coli, Clemennes, they used to, I mean, ceftriaxone used to be just the go-to. It was the antibiotic to treat all of these infections. But of course, what happens is that the gram negatives are really good about supercharging their beta-lactamases. And one of the ways they did that and overcame third generation cephalosporins was something called the formation of ESBL, or extended, for short for extended spectrum beta lactamase. So now all of a sudden these organisms could produce a beta lactamase that could cleave up third generation cephalosporins, and now you have drug resistance to ceftriaxone, Ceftaz, all these things. AMP-C is an inducible ESBL essentially, meaning you expose them to ceftriaxone. At first, it seems like you're killing most of them, but hiding away on a plasmid or on the chromosome, or it's integrated in the chromosome, is an inducible gene that produces that extended spectrum beta lactamase. And if you've killed off a bunch, and great, maybe that's all you needed, and you'll get better just because your immune system takes over. But maybe unfortunately, you're in this group where there's enough that survive that have a chance to start producing the extended spectrum beta lactamase, and now all of a sudden you're in trouble because now your third generation cephalosporins won't work. What's curious about the fourth generation cephalosporins is that they don't seem to induce the AMP-C gene. Even though rarely these ESBLs can actually cleave up the fourth generation cephalosporins, it doesn't get induced, and so it kind of stays quiescent and the bacteria dies. And so that's why we worry about it. Cefepime, like I said, doesn't induce it, which means if you happen to be an Enterobacter that has AMC, in general, cefepime will be a good choice. We still worry about things where it's going to be a long period of time. So if you have like a severe if you have either a severe ESBL or Enterobacter meningitis, for example, that's something where we'd probably just use a carbapenem to be safe. But cefepime is in general just fine. Um, of all these organisms, it's really Enterobacter that matters the most. Most of these others, even if they happen to have it, don't become clinically relevant. Again, if I had a Proteus meningitis in an infant, though very extremely rare, they do happen. I might be a little cautious. And again, uh, with some of these organisms. All right. In terms of fifth generation, that's where things, or advanced generation, that's where things get. Oh, and I'm sorry. And cefepim's other claim to fame is, of course, it's anti-pseudomonal, so it does have Pseudomonas. Yes. Unless, of course, it's resistant Pseudomonas, which can always happen. In terms of advanced generation, ceftaroline actually, although it works on MRSA, it's more similar to a second generation cephalosporin in terms of its gram-negative activity. So you generally wouldn't use ceftaroline for any other reason besides a MRSA infection. Don't use it, and certainly it's not good for most gram-negatives, so why bother? Cefiderocol is an interesting guy. It doesn't actually work on the cell wall. It seems to be involved in iron metabolism, so it has kind of this really broad range, very unique to it, and can also work on some of these really intense ESBLs, and not only ESBLs but also carbapenems producing bugs, which we'll talk about when we talk about carbapenems in a second. But in general, cefiderocol gets around that because it's actually more important in terms of the microbes' iron metabolism. So that's its own deal right there. But again, that's if you're using cefiderocol, you probably need to be asking for help with that infection anyway. So that's more on me and less for general pediatricians and general practitioners. But unfortunately, in the era of antimicrobial resistance, you might start seeing, 5 years from now, maybe this video will be out of date and everybody will need to be using ceftaz, avibactam, and cefiderocol and all this stuff. And hopefully, as we rapidly advance, or not hopefully, as we rapidly advance to the antimicrobial or the post-antibiotic era, we're going to start seeing more infections that nothing works on. And certainly, if you had to pick the worst offender of that, it's going to be Klebsiella and Pseudomonas, and maybe Acinetobacter. Those are the big guys. Steno maybe gets an honorable mention. Fortunately, it's not that virulent, so I don't think most people will end up with a problem. But these guys are really the big bad three. All right, where does that leave us? Cool. All right, I think we're done with the cephalosporins, which then leaves us. Maybe I'll just delete the whole thing. Here we go. And we'll just start over with the carbapenems. So the carbapenems are actually going to be a little bit easier in terms of discussing them. So in terms of carbapenems, what carbapenems do we have? Well, we have imipenem, and it actually comes paired with, it gets renally metabolized, so it comes with an inhibitor of that. You can't buy them, you can't buy them separately. They come as a package, so cilastatin, but essentially it's imipenem. You also get, we also have meropenem, and we have ertapenem. And ERTA is going to get a little asterisk. Okay, so let's just talk about the gram positives first. Do the carbapenems, all these three carbapenems, work on MSSA? Well, remember, they are essentially designed to be resistant to betalactamases. So will they work on MSSA? You betcha. Will they work on MRSA? No, they will not work on MRSA. Oh my God, did I? Oh no. Hang on, I gotta fix this before I ruin my whole. Let's just copy you. Hopefully I'll edit some of that out, but let's go down here, and you're getting erased. All right, so here we are back in our carbapenems, and do they work on MSSA? We already answered that question. You betcha. They work on MSSA, but do they work on MRSA? The answer is no. Remember, there's only one beta-lactam. that works on MRSA, and that was ceftaroline. The carbapenems just do not bind the PPP2A, and so if they don't bind the PPP2A, it doesn't matter if you're resistant to the beta-lactamase, you are dead in the water. Do they work on group A strep? Sure. Don't use a carbapenem to treat group A strep when you use penicillin. Similar, group B strep, don't use it, but yes, it works. Viridin's group strep, yes, but again, better choices. Pneumococcus is an interesting little deal here. So if we have highly drug resistant, the carbapenems are a little bit more potent than even the third generation or fourth generation cephalosporins. So if you have a drug-resistant pneumococcus, meropenem might actually be the answer for that 5%. A lot of times I'll ask people, what do we do with pneumococcal infections, or sorry, what do we do with a kid or an adult who comes in with meningitis? Well, what do they have? Let's say anywhere beyond the neonatal period, the big causes of meningitis are, think about it, Neisseria meningitidis, and of course pneumococcus. And yes, there's a lot of other things. You can have viral encephalitis, you can have viral meningitis, you can have listeria, you can have all sorts of other interesting bugs, but these are by far and large the two most common causes, and pneumococcus is probably up there. And what do you put somebody with bacterial meningitis on empirically? You put them on Vanc and ceftriaxone. Why the Vanc? And a lot of people will answer when I ask what's the Vanc for, they'll say MRSA. But how often does Staph aureus actually cause meningitis? The answer is almost never. Not to say never, never, because you never want to say never, but by far and large, the majority of Staph aureus CNS infections involve VP shunts. We've seen a few where somebody's gotten shot in the head, unfortunately, and now they have a penetrating head trauma or something else, and then the staph from the skin gets in there, but it doesn't actually de novo like getting into the blood. I mean, it'll destroy absolutely every other part of your body, your heart, your lungs, your kidneys even. But interestingly, this doesn't seem to, even when it's causing severe sepsis, just rarely crosses the blood-brain barrier. It just doesn't like it. Bones, joints, all the other tissues it likes to get. So the Vanc isn't really for that. It's for drug-resistant pneumococcus. Remember, if you've altered your penicillin binding protein so much so that the third generation cephalosporin won't work, then the only way around is to just completely go around the problem, and that's what Vanc does. Remember, Vanc works directly on the cell wall. We can talk about Vanc maybe after the carbapenems, um, but but really that's the deal. You're using the Vanc for those 5% of drug-resistant pneumococcus. Well, it turns out that actually meropenem is pretty good with this other 5% as well. Not perfect, but pretty good. You would probably still do Vanc in that scenario, but you might want to think about checking for carbapenem susceptibility and using it instead if it happens to be ceftriaxone resistant. All right. In terms of fecalis faecium, the carbapenems unfortunately are not very good. Weird to say that ampicillin is better than meropenem at treating a fecalis or faecium infection. Meropenem's a little bit better with fecalis than the other guys, but still not something you would generally use. All right. How about our gram negatives? This is, of course, where carbapenems shine. They'll treat, of course, E. coli, Klebsiella, Proteus, Enterobacter, Citrobacter, Salmonella, typhoidal Salmonella, drug-resistant typhoidal Salmonella, at least partially drug, or at least many drug-resistant forms, non-typhoidal Shigella. Pseudomonas is the one sort of difficult, some sort of weird one. Both imipenem and meropenem are good for Pseudomonas. Ertapenem just does not have anti-pseudomonal activity. You just have to know that. There's no other rhyme or reason. But you do have to know that, because if you're trying to use, oh, well, I can use a once-a-day ertapenem, that's fantastic, and since meropenem works for Pseudomonas, surely erta does, and the answer is, unfortunately, it does not. Will it work for Neisseria? It sure will. Unfortunately, hopefully we don't enter the era soon of gonococcal infections needing carbapenems, but we're probably heading there soon. Haemophilus, of course, it'll work. Moraxella, yes. Again, pertussis is a little bit of a strange beast. Will it work on atypicals? Answer, no. No atypical coverage. Remember, they don't have cell walls or they don't need their cell walls, so you won't get it. Do they work on gram-positives? Yep, they'll work on your gram-positive guys, with maybe the exception of C. diff as being the one difficult to treat one, and they absolutely will treat B. reg. So they're perfectly fine for severe intestinal infections, or above the diaphragm, below the diaphragm anaerobes. You've got them all. Curiously, TB, the carbapenems, especially meropenem, and IMI to some degree too, is useful for TB and some non-tuberculous mycobacterial infections. So meropenem can get through that mycolic acid shell and does work on the cell wall there. So we will see occasional use for multi-drug resistant TB. Meropenem can be occasionally used in that combination. All right. Um, just remember, unfortunately, we now live in the era of KPCs, uh, and the NDM1s, New Delhi metalloprotease 1, and Klebsiella producing carbapenemase, where they can cleave up meropenem, ertapenem, becoming completely drug resistant to our carbapenems and all the other guys. I mean, if you've got one of these, your ceftriaxone ain't going to get you through either. So that unfortunately is the era. Pseudomonas can also produce some of these metalloproteases, but it also is very good at pumping stuff out. So you can certainly see, and even E. coli and Klebsiella can too. So you sometimes, if you're on long-term carbapenems, you will see the emergence of E. coli's and Klebsiellas that are resistant to it just by virtue of pumping it out, even if they're not necessarily cleaving them up. And so that is unfortunately the era we live in, and that's where we start to think about pairing these, like meropenem vaporbactam, where you have a inhibitor that can inhibit these metalloproteases or carbapenemases, and then you once again use the carbapenem to kill the bacteria. But we are certainly in a scary era where sometimes even those don't work on the mutations that these guys can have. Okay, so I think we've talked about all of them. So let's actually talk about the toxicities, since we sort of glossed over them. And there's a few curious ones. So probably the most important one, and we haven't really talked about this very much, is the hypersensitivities. So let's talk about hypersensitivities quickly. And any drug you take, any antibiotic, anything can lead to hypersensitivity. One thing we had talked about was acute interstitial nephritis. So basically, any drug can. The penicillins are probably the most, besides sulfa drugs, are probably next in line for most common. Oh, and of course, the most common being the like ibuprofen and the NSAIDs. But if it's not NSAIDs and it's not sulfa, then penicillins are probably third in line for most common induction of acute interstitial nephritis and that kind of thing. But again, still very rare. But let's talk about the hypersensitivities. So I think probably everybody remembers the types, right? We have type 1, 2, 3, and 4. Now, I don't strictly follow the official guidelines here, but type 1 is definitely the most common, right? And that's the IgE mediated response. So hives, rash, or hives, and especially when you can get as bad as anaphylaxis, right, where you get tongue swelling, eye swelling, respiratory wheezing, and then unfortunately, like another one that I think people forget about is intestinal. So you can have intestinal anaphylaxis where you end up with hypotension. You don't necessarily get as much of the hives that you might get, but you can certainly have such intense vomiting, diarrhea that starts soon after taking, especially an oral dose of a medication that you have a hypersensitivity to. So that's probably one of the common ones. Um, Type 2 hypersensitivities are really confusing, especially when you read about them. There's a lot of different explanations. There's different people saying different things. It's sort of like, oh, it's sort of like acute antibody rejection sort of mediated. So I just kind of ignore this one. Type 3 hypersensitivity is something we do especially need to talk about with that, and that is the sort of the serum sickness kind, right? Or the where you get antibody complexes. Of course, the classic serum sickness is you've got a bad tetanus infection and you're given horse anti tetanus toxin, and that's where you end up forming these immune complexes that deposit into your joints and bones and kidney, and you can get kidney inflammation, and you can get bone and joint inflammation, and arthritis and fevers and all that stuff. And this actually, penicillin can in fact trigger serum sickness. So it is something you have to look out for, especially when you're on any of the beta lactams, but particularly the penicillins or carbapenems seem to be more related to that. Again, very rare, but it is something you go, okay, I started this, they've been on it for a while, and now weird things are happening and their joints are hurting and what's going on. Don't forget serum sickness. And it is very hard to remember, especially if you're just especially when a patient's complicated and you're adding all these things, and heaven help you if they also happen to have a room disorder on top of that, and now they get serum sickness from penicillin. It's really going to be clinically confusing. No two ways about it. Type 4 hypersensitivity is called delayed type, and that's the classic example of that would be, I think most people think of it as like poison oak or mangoes, interestingly. Also can do that. The mango tree has a similar sort of molecule as poison oak does, where it's T cell mediated, right? And that's it's the same as the PPD response to tuberculosis, right? All of these are delayed T cell mediated hypersensitivities. And while not strictly in this, I actually think of things like drug fevers and drug rashes. I just kind of lump this into weird complex immune phenomenon. Weird complex immune. So it is very common to get rashes, right? And a lot of the things that people will say is, okay, a kid had a cold and somebody decided, well, maybe his ear looked red, so I'll just throw on some amoxicillin for funsies, and then they get a rash, and what's that rash to? Most cases, it's to the virus, right? It was the viral infection that did it. But you can sometimes get weird immune phenomenon. You can get things like drug fevers, so we certainly have patients who, now, yes, you can get fever with serum sickness too, but it's a more distinct clinical picture. Whereas drug fevers are very common, and it's not that uncommon when you're on like long courses of beta lactams that everything's going well. The infection looks better, the patient's looking better, and then all of a sudden they start getting these fevers out of nowhere, and you're like, why are they having all these fevers? It turns out that there's a very good chance they're reacting to the drug itself, and we've certainly seen that. It doesn't necessarily preclude you from ever using it again in your life, but you do have to be careful depending on how weird this weird immune reaction is. But yes, drug fevers, those fixed rashes where it's not like hives, but it's like a fixed drug eruption, morbilliform eruptions, those kinds of things. Those can be these sort of more complex immune phenomenon that you will absolutely see with reactions to these, and probably one of the more common things you might end up seeing um, are like just weird rashes that aren't necessarily IgE mediated, but are sort of reactions to drugs. And whether or not you can give it again is really dependent on the response. There's plenty of times where people have had just a mild rash and that kind of thing that's not hives and not clear IgE mediated, that you just give them to them again, they're fine. You just have to kind of know that they've had that and challenge them, usually in a controlled environment. All right, so that's the common hypersensitivities. There's a few sort of nuanced things that we need to talk about. One is seizures. So one of the reasons we can't actually do intrathecal penicillin or that kind of thing for meningitis is because the beta lactams all can induce seizures, and that's why there is a therapeutic drug limit where we can't just give you more and more of those. And technically, all the beta lactams can do it, but the biggest offenders are still penicillin and the carbapenems. IMI and marrow would be the most common offenders. Uh, as a notable side exception, cefepime seems to also have a very specific neurotoxicity that you just have to know about, and just have to caution patients if they start getting dizzy, confused. If you have a patient who is otherwise seemingly doing better clinically from inflammatory markers and everything else, but is confused and delirious, and they're on cefepime for their Enterobacter or whatever infection they've got, just remember that cefepime has a additional neurotoxicity. But of course, if they're having seizures, then it could be any of these betalactams that are doing it. Other ones, oxacillin gets a big mention. Why nafcillin is probably in general preferred, but oxacillin is more available. Um, if you had one, if I had to pick one of the beta-lactams where I've seen more issues with drug rashes, drug fevers, neutropenia, all of these things, it's oxacillin, and hepatitis is oxacillin's other. Hepatitis is its other big claim to fame. Let's see. The beta lactamase inhibitors all love to cause diarrhea, with clavulanate probably being the absolute worst offender. And not necessarily C. diff diarrhea, just diarrhea. Just if you get a huge dose, especially if you end up giving somebody a whopping dose of clavulanate, they will end up with diarrhea no matter what you do. Um, and all can technically trigger C. diff, but again, much less so than Clinda and the fluoroquinolones in terms of offense. All right, I think that's a pretty good overview of these guys. So we can talk about a couple others that are clinically relevant.